introduce everybody to our conveners, Dr. Naushad Hussein and Dr. Niraj Vora. Sir, please come and sit here up front. I'd like to introduce our chairperson, Dr. Santosh Shetty. So please. We have a first speaker, Dr. Anil Bhatia, on 10 commandments of a revision femoral replacement, monoblock taper fluted system. Oh shit, I'm so sorry. Do we need modularity? Dr. Dipak Dave, sorry.
Yeah, my name is Dipak Dave. The topic is monoblock tapered fluted stem. Do we need modularity? So the learning objectives, we need to select a stem which is useful in majority of types of defects. It can achieve the joint stability and gives predictable stem positions, that's subsidence. And surgical technique should be easy, efficient and reproducible. This is the objective on which the talk is based. The femoral revision is a complex situation as we know because reconstruction in the presence of mechanically compromised femoral bone stock, we all know that. Paprosky classification helps us to define the bone defects, but we have to assess the defect only after the implant removal, which will help to decide about the implant. Various stems were available and are available now. Fully cemented, we know the high failure rates. Impaction bone grafting is a good, technically demanding, needs a bone bank. This solution type of fully coated cylindrical stem has the results of fractures and stress shieldings. So titanium tapered stems, either monoblock or modular, they came into the picture because the titanium material itself has a low modulus of elasticity, less thigh pain, and less proximal shielding, which was seen in the earlier designs of the cobalt chrome. The flutes gives a rotational stability like this fluted stem, and the tapered geometry is to give a axial stability. And the rough surface of the grid blasting, it promotes the bony ingrowth. So combining these three things together, you achieve the rotational stability, axial stability, and bone ingrowth. This is what you want. And this is a conical fixation principle. You actually, femur is reamed into a tapered cone and implant impacted into this tapered cone of the middle diaphysis of the intact and well-preserved bone, which gives you axial stability. So that reaming in a cone shape and putting a cone implant, that's why you need a tapered stem, which gives you axial stability. Here you can also do the femoral osteotomy. Example like modular stem which is broken, and after doing the ETO, you can actually reduce the length of the stem. So if you get a proper stability, your stem can be a short also. And we all know that various papers have been published on the monoblock tapered titanium fluted stem, useful in majority of the defects up to 3A. And there is not a single stem reported breakage so far in the English literature for the Wagner type of stem so far. And various reports have been there in the published. We all know that it is indicated in wide range, like aseptic loosening in this case, or a similar case where, or an infected case where you have removed the spacer and put this type of tapered fluted stem. It's a workhorse, we all know. But it had some issues. Subsidence, there was no horizontal offset options available, neck version was not there, and the impingement leading to stability and dislocation problems with this stem. Therefore, this modular design came into the picture, which gives you the distal fixation and proximal biomechanics, they separated. So by option of offset, version and leg length adjustment, you can have both the things together. And modular stems also gave a good results. The literature is available and a better scope to achieve soft tissue balance. This was the whole idea about the modular stem. And the rise of tapered modular fluted stem came into the picture. But nothing comes free, not a remedy, what PM Modi says. So problems are there with modularity also. It's not a good result with the high BMI patients, number one. Number two, when you have unsupported proximal junction, there is a chances of breakage, implant failure at the junction, technically more demanding, and learning curve is there, inventory you need more, and the cost is a factor. So we have already seen the modular stems breakaging because there is unsupported things. Subsidence is a main issue on which the debate was there, but the literature is quite differing. Seating the implant based on the leg length and not the axial stability, that is what we have to look into. And it is a surgical technique which is undersizing are responsible for subsidence. Here we have seen it is subsidence because of the undersizing and not the correct technique. And here we can see there is no subsidence. Can we combine both these things together? Fixation combined with biomechanics and hip stability. And there the third generation stem came. They changed the flute, they changed the taper angle, and the rough surface blasting also changed. They gave multiple length options, multiple diameter options, horizontal offset options. All these things what we wanted have been given into the newer design. And this monomod stem of the Meril has got 8 to 10 longitudinal ribs, HA coated in the proximal part. So it promotes the osseointegration. Rounded shoulders for the soft tissue irritation, and the bevel tip, which also helps in the lower part to prevent the fractures. And the taper angle has been made optimum. And this stem has got an additional feature of the highly porous proximal femoral augment, which prevent the secondary subsidence, because you can put it there and osseointegration can be achieved. Size starts from 12 for the Asian things. There are various length options, and 2 holes are also there. So you can put the trochanteric wiring. So a lot of designs have been done. The most important and last important point is surgical technique. Here it's the one stem only. It's not a modular stem. But you have to do the primary provisional rimming and then secondary scratch fit. This is a surgical technique which you need to learn. And after doing the fitting of the distal part, you adjust your soft tissue balance on the trial, which is like a modular. And then you use a stem, which is like a monoblock. So combining these two with a good surgical technique, you can achieve what you want in the modularity. So important is a bone RM, BRM. You have to mark that level, and on basis of that, you can decide your soft tissue balancing and use the same things. As we all know that these monoblock stems are useful in wide range of conditions, in a fracture, periprosthetic, loosening, infection, implant failure, all of these conditions where you can use this. And the last slide is that combination of ideal leg length, hip stability and implant stability. You want all. You don't want subsidence, you want the balance of the soft tissue. So if you do a proper planning and use these third generation monoblock stems which are designed to give you advantage of modularity, the monoblock and modular stems. And if you do a proper trialing and a soft tissue balance, your modularity can be made redundant. So these third generation stems like monomod by Meril, there is another stem also available, but it gives you wide options available to balance the proximal part, the soft tissue length, version, offset, and you can use a monoblock stem like a modular stem. Thank you.
Thank you, Dr. Dave, for this extensive elaboration on this new thing in the armamentarium of all the surgeons. To just keep up with time, what we'll do is we'll take the questions later so that we can have the other speaker.
I'd now like to invite Dr. Sanjeev Jain for his talk on bearing surfaces in the young hip.
So thank you so much. I'll be speaking on a COC, which is the preferred option, at least for me in very young patients. And then we are all aware of that, the fact that the osteolysis and wear is the major cause of failure because the bearing surface has a problem in the long term. Now, with invent of so many bearing surfaces, the science has evolved, and then we have ended in only 3 options now: ceramic and ceramic, or you have a ceramic on poly, and metal on poly. The ultra high molecular weight polyethylene, and you can say the cross-linked polyethylene, is an advent which is added. तड़का लगा देते हैं ना जिसको बोलते हैं. Okay, so that has a little bit changed the use of ceramic on poly, and probably has got a equal result as in ceramic and ceramic. When you go to the different registry, you find the different reasons, but the problem with the registries and different papers are that the subsets or age groups or the pathologies and material used, different kind of bearing surface used are different. But the prominently cause of loosening is aseptic loosening, and which was addressed by these new technology. Now, if you'd like to see the long-term results of the ceramic and ceramic or ceramic on cross-linked poly, it's debatable, and there's no long-term data available so far. So definitely the mid-term data are available, and which definitely are probably equal, but what what is important here, that these uses definitely depends on your experience rather than the surgeons. If you're good with one of the material what you're using all the time, you have good results in your hand, you keep on using those. But my preferred choice is in a young patient is definitely a ceramic and ceramic. Now, why? So definitely in a young patient, you have the new ceramic, which is there for a couple of years, the Biolox Delta, and which has got all the properties, all the material impregnated, which can also reduce the complications of the earlier ceramics available at that particular time. Advantage of one over the other is very difficult to narrate in the literature, but definitely since we are started using a crosslink poly, you can also use a bigger size of the head in both, in fact, but even in the ceramic and ceramic with a thinner liner, you can use a bigger head as well. You have a different kinds of material in evolution of the process of ceramic on ceramic, and then definitely a different head size, different tapered here and different tapered on the socket size to prevent the complications. So you have all the things which has been addressed in a newer design and which can be used definitely. There are definitely some drawbacks, and those drawbacks were because it was talked that in ceramics there are a lot of risks for the fractures, and which were not due to the material, which is because of the technique which you perform these knees and misalignment, metal back damage, or acetabular component malposition. Squeaking is a phenomena, is a problem, but it doesn't lead to any revision in general, and it has been also brought down. It was basically mainly pronounced in one of the company products in the past. What is important here is when you're doing a ceramic and ceramic, the positioning of the socket, which is very important, and you need to be very perfect in putting your socket in a proper position of inclination and the version. And if you do that correctly, and if you put your liner really perfectly correctly, along with your combined anti-version, I think you can have an excellent results, and long-term results should be good. There are studies in the literature which says definitely the ceramic on poly or ceramic and ceramic has no long-term data right now, and they are equal, but one of the studies shows the ceramic and poly is much better, but they are only focusing on few scores, not the long-term data or radiological scores there. Couple of examples, this patient was 43 years old, bilateral avian. Of course, I prefer to do, I can raise a lot of debates here. I prefer to do bilateral simultaneously same day in a young patient who is fit. And this is again a ceramic and ceramic hip done, and this is 3 years follow-up for that patient. Okay, of course I have a short-term follow-up right now with particular design. Time is up? Okay, this is another patient, definitely again had a bilateral hip done. Same day, patient had a CKD, and he was supposed to be for the renal transplant, but it was so painful that he was not even able to walk. Turning on the bed was very painful. And I did again the ceramic and ceramic, my indication, 43 years old, and he driving himself and he goes for dialysis every day. So it can give you a good function as well at the end of the day. Very difficult to accept that an 18 years patient with a non-union a TC fracture neck femur implant penetrating, you have nothing to offer. And again, she had a ceramic and ceramic hip, and she's performing well for again 3 years follow-up. So, if you see, the ceramic and ceramic is doing good in a younger patient. You have an option of using 32 to 36 millimeter head. The complications rates definitely have gone down, especially the fracture, and it's definitely, one has to say, it's not a material. I think it's for any technology or technique or any prosthesis you're doing it, it's a surgical technique and handling the component, which matters mainly, and positioning implants. So if you have all these three things, you do whatever implant you're doing it, whatever material you're using it, you'll have excellent results. Thank you so much.
Thank you, Sanjeev. Thank you. Just a reminder, the first notification would be at the time 5 minutes, the second would be 7, and the third would be at the end of 8 minutes.
Thank you, sir.
Okay, 7 minutes.
I now call upon Dr. Mayank Vijayvargiya for his talk on dual mobility.
Good afternoon, everyone. At the outset, I would like to thank the WIROC organizing team.
Wrong talk.
And the Meril team for having me here. So this topic is of great interest in current era because of the increased popularity of dual mobility in current years and the increased number of cases being done recently.
Should we switch? And yeah, since the, yeah.
Good afternoon, everyone. Thank you for being here. My name is Supreet Bajwa. I'm a hip and knee specialist. I'm practicing out of Mumbai at Naushad Hospital. I'd like to start off my talk on direct anterior hip replacement, if this can be a part of your armamentarium in India. My disclosures are I'm a consultant for these two companies, but my biggest disclosure is that I'm a trained posterior approach hip replacement surgeon. I'd like to start off by thanking my mentors in Australia. These guys paved my way for taking up an anterior approach in my practice. Anterior approach is not new. It was started in 1881 by Dr. Huter. He used them for his fractures, followed by Smith-Peterson, who went a little medially, but anterior hip replacement started by by the Jude brothers, who started using this approach for their acrylic implant in the 1950s up to the 1980s. In current literature, Dr. Mata and Dr. Stephen Krauser use an extension table for the hip replacement. I've done a cumulative about 25,000 hip replacement surgeries. Incidentally, this is also the table that I use in my practice. A question that's asked by multiple authors and multiple people I come across is anteriors really better than the posteriors or the conventional traditional approaches for hip replacement? And if there is any scientific backing for it. All the backing that has been done in these statements, in these slides ahead, are level 1 and level 2 studies. Concerns that I have seen from people who have encountered in my practice are whether they need to switch from the posterior approach to anterior approach, whether there's a steep learning curve, and a group of pacifiers who want me not to do anterior hip replacement surgeries, citing a risk of wound infections, no universal precautions for hips, technically a challenge, or the risk of femoral nerve injury. A paper in CORR published in about 2015 spoke about how anterior hip replacement causes less than 50% damage than conventional techniques for their hip replacements, but done by about 7 surgeons together. This was extended by a study in George Washington University where they assessed the biomarkers, and the results are shown on the right lower column, where 5 times less rates of biomarkers were seen in the anterior approaches to hip replacement. The prompt data and initial functional recovery is something that anterior hip replacement patients really accept really well. So WOMAC, HSS, and San Francisco scores at 6 weeks, 6 months, and 1 year were remarkably better in 2 cohorts, which were divided at the same Rothman Institute led by Dr. Javad Parvezi. For us younger surgeons who switch from posterior to anterior, a study was done and published in Journal of Arthroplasty, which spoke about how well we do our anterior hip replacements when we compare it to our own posterior hip replacement surgeries. And it says that intraoperative fluoroscopy helps us to position our components much better than compared to a posterior hip replacement. DA as a cumulative lower dislocation rate. This was a massive study consisting of 25,000 patients where the DA approached surgeons. It was the same group of surgeons who did DA and posteriors, and they found that their dislocation rates were less than half in their direct anterior approach hip replacement surgeries when compared to their posterior or conventional approaches to hip replacement surgery. Another couple of systematic reviews spoke about the VAS, incision length, blood loss, length of stay, and importantly, the infections. They were not more than conventional approaches to hip replacement surgery. In fact, were all lower in direct anterior approach to hip replacement surgery. American Association for Hip and Knee Surgery conducts a yearly survey. In 2003, less than 1% of surgeons in the US were doing a direct anterior approach to hip replacement. In 2018, 56% surgeons are doing it. Those are not the numbers that are replicated in India, and out of those 56%, most of them are also doing revision surgeries and complex anatomy anterior surgeries for all their primary hips. Same, in 2018, the John Charnley Award was given to a study which was done by 7 surgeons where they studied the gait analysis in the initial couple of weeks after a hip replacement. They compared the DAA group to the mini posterior group, and the results were astounding. All of them were better than the MIPA group. Does the DAA need any specialist equipment? Yes. Does it need an extension table? Not necessarily. But in my experience, the learning curves becomes much easier and the femoral exposure becomes much easier when you use an extension table. I don't endorse it, but I know that in my private practice, I've suffered greatly while doing a direct anterior on a plain table. One of the criticisms that you can ask about the DAA approach is if it's an extensile approach. I know that there are papers which say that it is an extensile approach. However, I do all my revisions posteriorly, barring a few simple revisions. In India, this is quite fair. Lack of a structured training program for learning DA is a problem that we all face as young surgeons. We have to either go abroad and learn our techniques. We do not have a structured training program for direct anterior approaches to hip replacement surgery, which makes the learning curve to be about 60 cases in our case. Most commonly, complications encountered by us young surgeons in those 50-60 cases are intraoperative femoral fractures. Fortunately, these are calcar fractures or perforations which do not need more than a circle arch wire or just a bypass stem. How do we mitigate the learning curve if you're a young surgeon? So these 6 factors really come into account. Reading the anatomy, viewing the hip differently than how you've been trained is very important. Reviewing your literature, credible literature, is very important too. Second, you do your observership, go into centers who perform direct anterior hip replacement surgeries on a regular basis, and attend cadaveric workshop. This is where an industry sponsor comes into the equation. An industry partner plays a very important role. Get formal training, get fellowships, and get in extended surgeon visitations, followed by a buddy system where your mentor comes to your practice and does 5 or 10 cases with you, for you, to elevate the curve. For a practicing surgeon, the diagram there makes a lot of sense. If you have a perceived level of competency and you have a desire to outdo it, it will motivate you to learn a lot more. It has been said that the learning curve for practicing surgeons who have done more than 1,000 hips is less than 20 cases. In my initial curve, patient selection is minimal deformity, and I stick to doing the cases with low BMI, low muscle mass, and long valgus neck. I use this particular table to do a direct anterior approach to my hip replacement in my practice in Bombay as well. This is my workflow. I have an incision. I don't take the bikini incision. I take the straight lateral, vertical incision. I expose the TFL, go into the circumflex, have a neck cut, do my releases, and extend the table. If I had to, I'll release the yellow and the green arrow, the yellow arrow signifying the piriformis and the green arrow signifying the obturator internus. I never touch the blue arrow, which is the obturator externus. My cheat code. This is what I've been doing and trying to develop with Meril Orthopedics. This is a intraoperative fluoroscopy software where we take preoperative X-ray, take another X-ray after trialing, and this gives us the values that we seek during a hip replacement, which makes this curve much smaller. In my personal series, my operative time has come down from 110 minutes to about 80 minutes. I've done about 59 of these cases. I've had 1 intraoperative fracture and 1 lateral femoral cutaneous nerve palsy. This is what you see. I saw it intraoperatively, a perforated lateral cortex. I bypassed it with a stem. And another case where my patient sent this to me, where he said lateral femoral cutaneous nerve palsy, which was reversed in about 6 weeks. My take-home message is, it's a safe and muscle-sparing approach. PROMs, biological markers, are comparable to the traditional approaches to hip replacement. Learning curve is inevitable. We have to mitigate it by engaging in a formal training program. I'm happy to take any questions from you, even after the presentation. Thank you.
Okay, so good afternoon, everyone. I would first like to thank the WIROC organizing team and the Meril team for having me here. This topic is of great interest in current times due to the increased popularity of dual mobility. Are dual mobility 2 heads better than 1? I would like to thank Dr. Agarwal and Dr. Shetty for sharing their cases and for their valuable inputs. These are the learning objectives from my slide. Over the years, in spite of so much development in design and technology, instability still remains one of the main complications after THA, with its incidence as high as 7% in primary cases and 25% in revision cases. Further, the instability rate increased by 1.5% with each passing year. However, in France, the dislocation rates are less as compared to the rest of the world. So why is this French paradox? This is because of the evolution and acceptance of dual mobility socket by Bosquet, where he combined two principles of Charlie's low friction inner head and McIferrar's stability concept of larger outer head, wherein during the initial range of movement, the inner head moves inside the outer head, and at the extremes of movement, the outer head moves inside the socket, giving greater range of movement. Further, the jump gap required for the head to come out of the socket increases significantly, giving greater stability. And this was proven in the initial studies where there was significant reduction in the dislocation rate. But what is the catch? Launched in 1974, but is still not popularized until the last decade because the initial studies were with the designer surgeons. There is increased risk of polyethylene wear because of its dural articulation and a higher intraprosthetic dislocation rate of 2 to 4%. This led to the evolution of dual mobility articulation with current design having a better acetabular cup, highly cross-linked polyethylene, better designed retentive chamber, and round small polished surface stem neck. And this led to a significant reduction in the wear rate in laboratories, and this was reciprocated in clinical data also, where a systematic review of literature showed that there was no intraprosthetic dislocation reported after 2007 in primary scenarios, and in revision scenarios, the dislocation rate was 0.2%. Accepted by US FDA in 2009, after that, there was a significant rise in the use of dual mobility and as well as the number of publications. So what are its indications? Basically, patients who are at increased risk of dislocation, elderly population, patient with fractured neck of femur, prior hip surgery, neuromuscular diseases, cognitive dysfunction, and in revision scenarios. We have our own share of experience with dual mobility hips, where we have published twice, once in JACOT of 150 cases done for varied indications, and where we have concluded that it offers the benefit of a stability and increased range of movement as compared to conventional hip. Another paper published in CCOT where 103 cases of fractured neck of femur done, and our outcome was functional recovery and range of movement was better in dual mobility group as compared to conventional hip. And these are some of the cases. Degenerative arthritis, elderly population, prior hip surgeries, case of excision hip, fracture polio, revision scenarios, revision of bipolar to dual mobility hip, and salvage of a typical femur fracture with dual mobility. We have our own share of complications. One was loosening and failure of acetabular cup, which was revised with a cage and cemented cup, a case of superficial surgical site infection, and a case of intraoperative fracture, which was fixed. Now coming to evidence. Is it beneficial than 22.2 mm head in terms of dislocation? It's a no-brainer, obviously. Studies have shown clearly. What about 28 mm head? Studies have shown that the dislocation with 28 mm head was higher as compared to dual mobility group. When compared with 36 mm head, one would argue that with the current design, with the ability of large heads, there is no role of dual mobility socket, but studies stand otherwise, clearly showing that the benefit of dual mobility is far more better in terms of preventing dislocation. When compared with large head metal on metal and constrained hips, there was no difference in terms of dislocation rate. What about registry data? The European registry shows clearly benefit of dual mobility in prevention of dislocation, and that was the reason in 2017, American Joint Registry has shown that 10% of all the primary hips done in 2017 were dual mobility. When coming for different indication, dual mobility hip has better advantage in preventing dislocations in obesity, cerebral palsy, Parkinson's, neuromuscular diseases, as well as in revision scenarios for varied indications. So friends, it may look like we have got a solution for a problem which was long existing. But the question which still remains is, kitna chalega? How long should it last? So for that we have to understand how long a conventional hip lasts. Based on a review literature published in Lancet, it says that based on case series, it lasts 25 years in 77% of the cases, and in registry data, 25 years in 58% of the cases. The primary designer series shows a 80% survivorship at 22 years with the use of dual mobility socket and 70% at 25 years. Now this was the primary first generation cup. Assuming that the newer generation has better metallic properties, it should last longer than the first generation. But this long-term survivorship data is coming from the primary designer series. What about its result when used by other authors? Based on a systematic review of literature, when done around 10,000 primary hips, the survivorship was 98% mid-term. Another revision scenario, mid-term survivorship was 96%. The long-term survivorship data from other authors is still not available. To conclude, my friends, dual mobility hip is a good solution for instability. It gives good early results which are comparable and may be better than conventional hips. In our study, we have seen that most of the patients were able to go back to their pre-injury activity levels, and mid-term survivorship is equivalent to conventional hips. Thank you.
Thank you, sir. Our next speaker is Dr. Ameet Pispati, who's going to speak on proximally coated stem.
Good afternoon. Thank you very much. This is a topic that's been allotted to me. Is the proximally coated stem a change waiting to happen? Now, I'm sure having looked at this conference for the last 2 days, you realize what choosing a hip replacement is all about, right? You've seen the number of vendors upstairs, and pretty much it strikes me that almost everybody here manufactures hip replacements. By and large, if you put your hand on your heart, I'm sure you realize that you decide your stem primarily based on the relationship with your vendor, the comfort of doing the hip replacement, and finally, on the longevity of the hip replacement itself. Now, given that there are different kinds of cementless stems. You have the fully coated cylindrical, which could achieve diaphyseal, or largely in this part of the world, the one that we use is the one that achieves metaphyseal fixation. Or you could have a proximally coated tapered stem, which achieves a proximal fixation. So are there any disadvantages to using fully coated stems? Mind you, the larger market share is the one with fully coated stems. Technically, the disadvantages to using such stems would be thigh pain and femoral stress shielding. But is there any advantage to using a fully coated stem? Well, yes. By and large, the main advantage has been the history of that kind of stem, because the first implantation was way back in 1986. It was FDA approved in 1998, and the intramedullary design at least has been unchanged since 1986. And we know from past recalls and etc. that some of us have all been through, that history itself is very important. Longevity is what decides things in a hip replacement. So in terms of a fully coated stem, that's available to us in this part of the world, you will largely have a straight stem with a quadrangular cross-section, which has horizontal and vertical macro and microstructures, and it's fully hydroxyapatite coated. It works on a fit and fill concept, and it gives you a 3-point fixation, and you got to achieve primary mechanical stability there and then intraoperatively. You have got to have axial stability and rotational stability. You don't have to put in the biggest mother of a stem that goes in at the time. So it's not a canal filling stem realistically, and it gives metaphyseal loading. Now, whether you consider a proximally coated stem or a fully coated stem, multiple studies have shown that you have 98 to 99% survivorship at 10 years for either of these stems. So it really doesn't matter technically which stem you're going to use. Now, this was the benchmark paper quite some time back in the year 2010 by McDonald, by Rorabeck, and by Robert Barak. It was a multi-center randomized control trial, and it confirmed that both the fully and proximally coated stems performed well with no clinical differences between the two. And then you had a paper over here itself from the JJ Hospital, which was a retrospective study, compared the proximally coated ML taper stem with the fully coated Korai stem, which showed no difference in clinical outcome scores or thigh pain for that matter. So then, why would one at all want to consider a change? Simply because what you need to do is restore anatomy to the patient. It's not about putting in a stem and going home and just giving pain relief. Patients in the modern world want a lot more than a THR. A fully coated stem that's available to us may not be suitable for every single patient because the offset that it provides may not be appropriate for everybody. It may also be challenging to revise a fully coated stem when the time comes for a revision. So have a look at this particular X-ray. So there you are. Preoperative templating having been done, you plan for a total hip. You see now if you go to restore the anatomy, that's the kind of offset you need to give. And if that's the kind of surgery you do, compare both sides, you're given an increased offset to the patient. What that's going to do is giving rise to lateral trochanteric pain and limb length discrepancy, and clearly this patient is going to be unhappy with that. So is there any disadvantage to using this kind of fully coated stem in every single patient? Yes, the offset of this stem is considerably large compared to a proximally coated stem. And if you look at the smallest size of a stem, the horizontal offset is 38.3. Compare that to a cemented Exeter standard stem, which is used in an Indian population, 37.5 offset, versus a high offset stem, which they have a 44. So you're already inbuilding a high offset. So that's going to be suitable only for a certain group of patients, not randomly for every single patient. Now compare that to a proximally coated stem, and the smallest stem has an offset of 36. If you go to a commonly used stem, which may be a 9, 10, or 11, 38, 38.6, 39. So clearly you have the option of using this, and if you wanted to increase the offset, you could use the high offset stem and build in an offset as appropriate, rather than fixing yourself to a generally high offset stem. What about ease of revision in both? So here you are. Here's somebody who's had avascular necrosis, 1987, had this sort of a fully coated coral stem, and then you are 15 years later, and then eventually the question is, what do you do when it comes up for a revision? So here's one of our own cases, a fully coated stem over here. We needed to revise this, and you can see the kind of difficulty that you have getting the stem out, full bone ingrowth all the way top to bottom, and then you need a substantially long extended trochanteric osteotomy to get this stem out. Another of our cases also which needed a revision, and I had to do a significantly long ETO to get the stem out. So more morbid surgery, longer operating time, longer recovery time as well. So if you've got a fully coated stem which you need to remove, and if you just put this in unnecessarily, your ETO is going to come up to about here. With the proximally coated stem, if you need to revise it, your ETO is going to come to about here. So much shorter surgery, less amount of bone that's going to be removed. So the proximally coated stems act a little differently compared to the fully coated stems because they are tapered in the ML and the AP planes. They give you all the advantages of a tapered shape. They lock into the stem in the canal in the medial and lateral cortices, and they too enhance the rotational stability. And you have the options over here. You can have a standard offset. You can play about with the offset intraoperatively. So given these two reasons, I suggest there's good reason to be open-minded about these kind of stems simply because you have the option to play about intraoperatively. Not every patient is suitable for a proximally coated, for a fully coated stem. And I think if you keep these things in mind, then you are most likely to come out with a winner on table. Finally, with these kind of current stems which is available with this manufacturer, you can have the option of adding a DM system, you can have a bipolar, or you can have an uncemented cup as well. And that way your patient and you can win all the time. Thanks so much.
I guess it's time for questions from the floor. And if I can have all the faculty over here.
Question to Sanjeev. A very interesting small bone preserving stem. What make is it?
This is Traloc.
Who makes it?
I have a question for Supreet. You mentioned that in your list of complications that you had 2 femoral fractures with a calca heart fractured. Now, I'm a posterior surgeon, right? My question to you is that, was that because of the anterior approach or was it because of your enthusiasm to get in a better fit?
Small room, we can listen what he's saying. Okay.
Yeah. Exactly. So I had one intraoperative complication. That was not a calca fracture, that was a perforation of the canal. Now, that was not a complication of the approach. That was, if I may say, the incompetency of the surgeon. So I did not lateralize my approach enough. I was too zealous, and that patient was done on a table-less anterior approach. So when I came back to India, I had a patient with a BMI of about 40. I was too zealous to do the anterior approach. I did it on a routine table, and I had that complication because I was putting the stem into varus. My hand wasn't down. So that was a technical inadequacy and not something that the approach really does.
Approach specific.
It was my fault.
No, Niraj, this approach, it's your first insertion which causes the perforation. Then you realize that it's wrong, and then you bypass it by getting the angle right.
Exactly.
And then you get your tight fit. So this is not the start.
No, that's what. So I'm just saying that don't mind me saying it, I'm a bit blunt, but don't give the approach a bad name by mentioning this as a complication.
Yeah.
Because you'll put people off from doing it.
Yeah.
This was, we've all done this, it's not that. So, you know, it was due to surgeon error.
Absolutely,
rather
sir.
than being approach specific.
Absolutely, sir. I just wanted to own it up on stage by saying that I've had complications as well, and I don't, my fault, not the approach.
One question for you. You've been talking about this table time and again. What is so different about this table?
So,
to stop again. You mentioned that it can be done on a routine table also.
Yes, sir. It's just the learning curves. I think that's the difference maker. The table is more predictable, more reproducible. So somebody who manually controls your leg, your femur in mobilization, does not know how the status of the osteoporotic bone. And that's what I struggled with initially as well. So I did a couple of them without the table until the table was in my capacity. And I was at the mercy of the leg man. And I don't find that comfortable at all, and especially in the initial learning curve. So I myself am in the initial learning curve. So I propose the use of something that makes your surgical approach more predictable and more reproducible. And that's where I say that I use the table. It's definitely not a necessity to do an anterior approach using the extension table. You do need the instruments for it, but not the table. So I don't endorse it.
Because I think even in posterior approach, the person holding the leg is very important. So it does not matter whether it's anterior or posterior.
But you see the Judes, I've seen Thierry Jude doing his work, and I had sent one of my juniors to France, and it's a huge advantage having the table because you can adjust the position exactly as you want it. You can externally rotate it. The leg stays in one position reliably, and then you can just concentrate on a sensible insertion.
So basically what you need is a hyperextension of the hip when you're putting the femur in, and then you can do in even a normal table, which I do it very often, but if you have a table, nothing like it. But again, you have to be used to table. The person who is handling the table also be your person all the time. So technically, it's a demanding thing, but as Dr. Chennai says, it's the first entry. I think you need to be very careful about it, making the first, identify the GT properly, releases whatever is needed. That is very important.
Sorry, sir. In my initial cases, I think the biggest problem that I was having was I wasn't able to expose the area, the superior capsule around the GT. And doing it on a plain table, I wasn't getting the external rotation. I was able to rotate the limb to 90 degrees only. Whereas when I use something like this, I'm able to rotate it 140 degrees, which exposes a lot of the superior capsule and gives me a better femoral exposure. So for me personally, that's the advantage as well.
I think one important point that's coming out of all of this is a bigger, more philosophical point, is that never ever try to operate in a setup you're not familiar with. Find it. So, you may want to, your friend will say, come to my OT and do the case. Either you go there, make sure everything is there, or don't go. I think that's very important because he was not happy with what he had, and that's probably what, Now, I want to, sorry.
I guess Sanjeev also has an experience.
Yes, I have a huge experience with the DA, but the thing is that DA is not for all the hips or every hip. So you have to be very choosy about the DA when you're doing it. It's not for the fractured neck in general who are osteoporotic. So you have to be very choosy. When you are learning DA, you have to go to the centers. You have to be really, really good in anatomy. You have to do a lot of cadaver, and then you start DA. And possibly the instrumentation is the most important thing, and especially the femoral holder, which is the most important thing. You need to have, all company doesn't have that. So you need to have that kind of system with you, then only you start. And always have somebody who has done it,
A bit more. Mayank, my question to you is that what percentage of your total hip replacements do you put in a dual mobility?
So basically I've pointed out my indications. So for those indications, 30%.
So why not the other 70 if you think they're both the same and the dual mobility has a lesser risk of dislocation and everything? Why isn't it 100%?
So I am not using it for even patients who are young because I am still awaiting the long-term survivorship data in other hands. Although the long-term survivorship data from the primary designer series is there, 25 years. But I am awaiting for the other also to opine.
Fair enough.
Question to Ameet.
That's a very interesting thing. That's very interesting because my dual mobility, initially I was worried about the bearing surface. And I was saying, convex poly in a concave metal, which was where Chandli had a problem, but that was Teflon. This is a better polyethylene. And very easy technique, very encouraging results from the world over. And like he says, it's 30%. Now Vivek, Sanjay, and even me, we've started doing it in the younger patients. And I think it's going to last. It's looking good.
So you think your practice, you're going to do more and more of
I'm already at 50%.
Okay. Dr. Pispati,
I think
which
one of the
femur
papers
condition you will not use the proximal coated stem? Any specific indication where you will not advise to use that stem?
Yeah, it depends. I mean, if there's a significant mismatch between the metaphysis, diaphysis, then that also is a problem situation. That's one way I wouldn't use it.
Okay, I think we've run out of time.
One question. So is that the dual mobility is overrated?
Well, what is
for
it
the instability, like
everybody's talking
about the dual mobility. You've been doing it years together. Even if you do a good channel today, it will be a stable hip.
Sanjeev made very valid point. You've got to get your implant positioning correct, then everything works. So if you put a vertical ceramic cup, there's going to be a huge disaster. And it was the same with metal on poly also.
So I agree with you that the acetal position has to be perfect. It's not at the cost of your faulty positioning, but with the use of dual mobility, you have little bit of things to err because it will give you better stability.
You have a little margin for error. Ceramic on ceramic, you got to be very accurate. I think that's the worst part of ceramic on ceramic is you got to be so accurate that there's really no room for error. Whereas with this, you have a little bit of wriggle space. Anyway, I think we have to end the session. It's 3 o'clock. Thank you everyone for your attention and see you later.